You know, usually when we talk about a medical diagnosis, there's this expectation of just like absolute precision.
Right. It feels like engineering almost.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, well, there it is. Problem solved.
And we crave that.
Yeah.
We really crave that visual certainty. We want our medical problems to be neatly categorized, strictly biological, so we could just apply a biological fix and like move on.
But then you stepped into the world of chronic illness.
Oh, yeah. That's a whole different ballgame.
It really is. You look at something like heart failure, and suddenly that x-ray machine is just broken. The diagnostic landscape gets incredibly murky.
It does.
And that is exactly why we are here. Welcome to the deep dive. Today, we're trying to fix that broken x-ray machine for you.
Yeah, we've got a fascinating one today.
We really do. We have pulled data from 4 massive, completely separate medical studies to answer one hidden puzzle. And that is when a patient with cardiovascular disease or heart failure leaves the hospital, why do they end up coming back?
Because treating the physical pump of the heart, it just isn't enough anymore. Heart failure is literally the leading cause of hospitalization for older adults in the U.S.
Right.
So to truly understand a patient's health trajectory, you have to look at their zip code. You have to look at systemic demographics.
Yeah.
You even have to look at their physical senses, literally their ability to hear and their own internal intuition.
It's wild. So we are pulling from 4 distinct articles today, and they use entirely different data sets, ranging from like local patient records at the Duke Heart Center to the massive nationally representative health and retirement study.
But they're all tied together.
Exactly. They are all tied together by this relentless focus on uncovering the non-clinical traps that dictate a patient's survival. So let's start with the physical space a patient returns to after they are discharged.
Okay, yeah.
I'm looking at this first research paper by Dr. Radha Thingra and her team, and they focus heavily on this metric called the Area Deprivation Index.
Right, the ADI. So the Area Deprivation Index is a composite measure of neighborhood-level socioeconomic disadvantage.
Okay, so what does that actually measure?
Well, it quantifies how disadvantaged a specific census block is by factoring in local education levels, employment rates, housing quality, and median income. And Thingra's team used this to challenge a really major blind spot in modern medicine, which is this obsession with 30-day readmissions.
Yeah, that 30-day window, focusing only on a 30-day readmission window is, it's like judging a marathon runner's entire career based solely on the first mile of their very first race.
That's a great way to put it.
You just completely miss the big picture.
You do. But the entire healthcare apparatus is geared toward getting a patient past that 30-day finish line, primarily because of programs like the Hospital Readmissions Reduction Program.
Right, where hospitals are financially penalized if too many patients bounce back within a month.
Exactly. But from a patient's lived experience, that metric is highly flawed. For one, about 80% of hospitalized heart failure patients don't experience a readmission within 30 days.
Wow, 80%. So Thingra's team decided to zoom out.
Yeah, way out.
They tracked 5,889 newly diagnosed heart failure patients who were 65 and older, and instead of stopping the clock at a month, they followed them for a median of 5.6 years.
And some patients were tracked for up to 8 years.
Which is huge. So what happens when you stretch that timeline out like that?
Well, over that expanded timeline, 71% of these patients had at least one hospital admission.
Okay.
But here's the really interesting part. When the researchers looked at the short term, those early 30, 90, or 180-day windows, the neighborhood disadvantage didn't actually seem to drive the outcomes.
Wait, really?
Yeah. Once they adjusted for how sick the patients were at baseline, the neighborhood risk just vanished. In those early weeks, the clinical severity of the failing heart is really what dictates hospital readmission.
Okay, well, that makes sense. The immediate biological crisis is still the loudest voice in the room.
Exactly.
But what happens over the long haul, like years down the line?
That is where the neighborhood sinks its teeth in. Over years of recurrent admissions, patients living in highly disadvantaged areas had an 11% higher risk of ending up back in the hospital compared to those in less disadvantaged areas.
11%. That's not insignificant.
Not at all. And this excess risk was stubborn. I mean, it stayed there even after adjusting for the patient's individual sociodemographic background and their clinical comorbidities.
Okay, so how does a neighborhood actually put someone in a hospital bed? Like, give me the mechanism here. How does a zip code translate into cardiac distress?
Well, think about what heart failure management requires. It requires extreme diligence. You have to severely restrict your sodium intake to prevent your body from retaining water, right?
Because otherwise it backs up into your lungs.
Exactly. Now, imagine a patient living in a highly disadvantaged area, like a food desert.
Oh, right.
The only accessible food source is, a corner convenience store stocked with highly processed, sodium-rich foods. They eat what is available. Their sodium spikes.
And their body retains fluid.
Yep. The fluid builds up in their lungs, causing pulmonary edema, and suddenly they can't breathe.
And they end up in the back of an ambulance.
Exactly. Add to that, like, a lack of reliable transportation to make it to ambulatory follow-up appointments.
So their medications aren't adjusted in time.
Right. The neighborhood basically creates this slow, compounding deficit.
Think about it. Imagine you're taking care of your aging parent. The cardiologist gives you this complex fluid restriction and low sodium diet plan. But if the environment you are returning to physically cannot support those guidelines, that medical advice is practically useless.
It really is. The patient's residential address is quite literally a clinical tool for predicting their long-term health.
Wow. Okay, so if the neighborhood is this constant grinding weight, pulling a patient down over the years, does everyone sink at the same rate? Like, does everyone with heart failure follow the exact same path?
The data tells us they absolutely don't. And this brings us to the second study by Dr. Matthew Dupre and his colleagues.
Okay, the trajectory study.
Right. They wanted to map out the actual longitudinal trajectories of hospitalizations following a heart failure diagnosis. So they used electronic health records from over 5,600 newly diagnosed patients, tracking them for up to 5 years.
And they used trajectory models to group these patients based on how their hospital admissions clustered over time, rather than just looking at, like, the overall average.
Yeah, because averages hide a lot of the real story. They actually identified 4 distinct groups.
What were they?
The largest group, making up nearly 46% of patients, was the low-risk trajectory. They had very few admissions over the 5 years.
Okay, 46%? That's almost half.
Yeah. Then you had the early risk group at roughly 37%. They experienced a high risk of admission right after their diagnosis, but it eventually tapered off as they stabilized.
Right. Then there's the late risk group at about 10%, right? Whose admissions steadily climbed a couple of years into their diagnosis.
Exactly. And finally, the smallest but most concerning group, the consistently high risk trajectory. That was about 8% of the patients. These are the folks who are just constantly bouncing back and forth to the hospital.
Yeah, and I was looking at the demographic breakdown for that consistently high risk group, and the disparity is just alarming.
It really is.
Non-Hispanic Black patients were about 90% more likely to be in that high-risk group than non-Hispanic white patients. I mean, I have to ask the uncomfortable question here. Is this a biological difference in how the disease manifests, or is this a reflection of the systemic environment we were just talking about?
It is largely systemic, and the researchers didn't just document the disparity. They actually wanted to isolate the drivers behind it.
Okay, how did they do that?
Well, when they mathematically adjusted the data for both clinical factors like diabetes or kidney disease and non-clinical factors, the picture changed dramatically. Over half of that excess risk, about 56% of it, was completely explained away by those surrounding circumstances.
Wow. So over half the disparity isn't the heart muscle itself, it's the environment.
Exactly. And tying it directly back to our first study, the single biggest non-clinical driver contributing to this racial disparity was the Area Deprivation Index.
Oh, the ADI again.
Yeah. Neighborhood disadvantage alone accounted for roughly 20% of that disparity.
So living in a disadvantaged zip code is literally dragging these patients onto a more dangerous, accelerated timeline of hospitalization.
Yes.
So what here is really the timing of the intervention, right? Like, a diagnosis of heart failure is this incredibly fragile window. If you are a healthcare provider and you know a patient's zip code is pulling them toward a consistently high-risk trajectory, you can't just send them home with a glossy pamphlet and hope for the best.
No, definitely not. You need a protracted care management plan, you need social workers, you need logistical support, and you really need to address the long-term realities of maintaining effective self-care for patients from disadvantaged backgrounds.
Okay, so we've zoomed out to the zip code and we've looked at the 5-year timeline. Let's zoom all the way in to the actual exam room.
Okay, I like that.
Because what happens during the immediate physical interaction between a patient and their doctor?
This brings us to a fascinating and, honestly, often invisible comorbidity: physical senses. Specifically, our third article by Dr. Jessica West and colleagues, which investigates the impact of hearing loss on heart failure patients.
This statistic made my jaw drop, honestly. They used data from the Nationally Representative Health and Retirement Study following over 3,000 adults diagnosed with heart failure. And they found that upwards of 75% of older adults with heart failure also have hearing loss.
It's staggering, 75%. And we have to remember the mechanics of managing heart failure. It is an intensely active process for the patient.
Yeah, it's not a passive illness.
Not at all. You have to restrict your fluid intake. You have to step on a scale every single morning to check for sudden weight gain, indicating fluid retention. You have to juggle a very complex regimen of prescribed medications, and you have to monitor your own breathing patterns.
It's practically a part-time job.
It really is, a job that relies entirely on nuanced communication. So West's team categorized these patients into 3 groups: normal hearing, unaided hearing loss, and aided hearing loss, meaning they wore hearing aids. Adults with unaided hearing loss had a 14% higher rate of hospitalizations compared to those with normal hearing.
Okay, but I look at that finding and I immediately have to push back a little because hearing aids are famously expensive.
They are?
They run into the thousands of dollars and are often, entirely uncovered by basic insurance. So isn't this just a proxy for wealth? If you have a hearing aid, you're probably wealthy enough to afford better groceries, safer neighborhoods, and private doctors.
And that is exactly what the medical community assumed for years. It sounds like a pure wealth proxy. But the researchers anticipated this skepticism, and they explicitly tested for it.
Oh, they did?
Yeah, they used rigorous statistical models to account for a vast array of sociodemographic and health-related characteristics. They adjusted for educational attainment, and crucially, they adjusted for household wealth, like literally calculating the patient's total assets minus their debt.
Wow. And the gap was still there.
The gap was still sitting right there, staring at them. Even after mathematically stripping away bank accounts, property assets, and baseline comorbidities, those with unaided hearing loss still had significantly higher hospitalizations.
That is wild.
But here's the mechanism that really proves the point. Adults with aided hearing loss, those who actually wore their hearing aids, had no significant difference in hospitalizations compared to adults with normal hearing.
Wow. Okay, so how does losing your hearing literally make your heart fail sooner? What is the actual mechanism happening here?
Think of it like this. Trying to manage a complex chronic illness with unaided hearing loss is like trying to defuse a bomb through a foggy window.
Oh, man. That's a great analogy.
You simply don't have the sensory input required to execute the delicate tasks. You can't hear the doctor explaining how to titrate your diuretic dosage. You can't hear the pharmacist warning you about a drug interaction.
Or even stuff at home, right?
Yeah, exactly. You might not even hear your spouse pointing out that your breathing has become labored while you're just watching television. The hearing aid isn't just an acoustic device. It acts as a critical tool for medical adherence.
It bridges the gap between the medical advice and the patient's reality. It is just wild to think that an audiology appointment might be just as critical to keeping a heart failure patient alive as a cardiology follow-up.
It really proves how deeply interconnected our sensory systems are with our internal organs. Communication is just the fundamental pillar of chronic disease management.
Okay, so we have the neighborhood outside the window, we have the trajectory of the disease, and we have the ears taking in information. For this 4th and final study, we are going completely inside. We are looking at the patient's own mind.
Yes. This is the study by Dr. Hanzhang Xu and colleagues, and it tackles a concept that the medical field usually finds very difficult to quantify.
Patient intuition.
Yeah. Exactly. Xu and their team conducted this study at the DUPRI Center. They recruited 730 patients who are currently hospitalized for cardiovascular disease. And right before these patients were discharged, the researchers did something incredibly simple.
They just handed them a survey, right?
Yep. They asked the patients a direct question. What do you think your risk of being readmitted to the hospital within 30 days is? They essentially asked the patients to perceive their own vulnerability.
You know, this reminds me of the check engine light on a car.
How so?
Well, sometimes you take your car to the mechanic, they plug it into the diagnostic computer, and the computer says, everything is fine, fluid levels are optimal, tire pressure is good. But as the driver, you just feel it.
Right.
You feel that slight hesitation in the transmission when you shift gears. You just know the car is going to stall on the highway.
I love that. And it's so true here. The medical chart might say the patient is stabilized, their vitals are normal, and they're cleared for discharge. But the patient's lived experience, their knowledge of their own body, the stress waiting for them at home, the empty refrigerator, it all tells them otherwise.
And the findings were remarkable. The patients basically nailed it, didn't they?
They did. Those who perceived that they were at a high risk of readmission actually had a significantly higher rate of returning to the hospital within 30 days compared to patients who perceived a low risk.
That's incredible. Who are these patients that knew they were going to crash?
Well, the data showed they tended to have lower levels of education, were less likely to be employed, had lower levels of social support, faced more life stressors, and exhibited more depressive symptoms.
So they were acutely aware of the fragile, unsupportive ecosystem they were returning to.
Exactly.
But the study also brings in some fascinating and honestly slightly tragic nuance.
Yeah.
It wasn't a perfect one-to-one correlation for everybody, right?
Yeah, it was.
The study noted that widowed patients who perceived a low risk of readmission actually had a surprisingly high rate of ending up back in the hospital. Why would they think they are fine when they so clearly aren't?
This is where the data tells a deeply human story. Without a spouse there in the house to help monitor symptoms, the patient's internal intuition is just flying blind.
Oh, wow.
Yeah. A spouse acts as an external vital sign monitor. They are the one who notices if you are suddenly gaining fluid weight in your ankles, or if you are sleeping propped up on 3 pillows because you can't catch your breath.
Right, because when it's happening to you, you might not notice the gradual change.
Exactly. Without that daily reality check, these widowed patients developed a false sense of security. They didn't realize they were slipping into a crisis until it was a full-blown emergency.
That is heartbreaking. It just shows how vital another human presence is to our own self-awareness. And there was another major disconnect in the study regarding race, wasn't there?
Yes, there was. Among the patients who accurately perceived they were at a high risk, non-white patients were significantly more likely to be readmitted within 30 days than their white counterparts.
Even after adjusting for everything else.
Yes, even after adjusting for socioeconomic backgrounds and clinical characteristics.
So they knew they were in trouble, but they couldn't stop it.
Exactly. It highlights a painful reality of the healthcare system. Simply knowing you are at risk, having that perfectly accurate intuition, isn't enough if you lack the systemic resources, the timely ambulatory care, or the structural support to actually prevent the crisis.
Intuition without resources is just anticipation of failure.
That's exactly what it is.
That is heavy, but it is so vital to understand if we actually want to fix this system. So let's pull all this together.
Okay.
We started by talking about the X-ray, that deep desire for a clean, binary medical diagnosis where we can just point to the raw pumping power of the heart muscle and say, there's the problem.
And we've seen just how inadequate that narrow view is for chronic illnesses.
We really have. When we ask the question, why does a heart failure patient end up back in a hospital bed? The answer is almost never just about the heart.
Right.
It is about their zip code and the sodium-heavy food desert waiting for them at home. It's about the systemic long-term disparities that lock them into high-risk trajectories for years. It's about whether they can literally hear the complex instructions their doctor is giving them to defuse the medical bomb.
Yeah.
And it's about their own internal intuition and whether they have a spouse sitting in the living room to make that intuition accurate.
I mean, imagine navigating this system yourself. Or trying to manage the care of an aging parent. You have to look at the whole picture. Medical care does not happen in a vacuum. It happens in neighborhoods, it happens in conversations, and it happens in the patient's own mind.
It is all connected, which leaves me with a final thought for you to mull over. We've seen how undeniably powerful these non-clinical factors are.
We really have.
We've seen the mechanism of how unaided hearing loss spikes hospitalizations, while simply providing a hearing aid neutralizes that risk. We've seen that neighborhood deprivation alone drives 20% of the racial disparity in long-term hospital trajectories.
Yeah, the numbers don't lie.
So if things like neighborhood support, self-perception, and hearing aids are ultimately what dictate heart health outcomes, it makes you wonder, should the cardiologists of the future be prescribing subsidized housing, mental health check-ins, or hearing aids right alongside their blood pressure medication?
Until we treat the context the patient lives in, we aren't truly treating the patient at all.
Absolutely. Maybe someday the medical x-ray of the future won't just scan the chest, it'll scan the neighborhood too. Thank you so much for joining us on this deep dive. Keep asking questions, look at the big picture, and as always, stay curious.